Hello and welcome to the Spinal Cord Injury Forum. My name is Jeannie Hoffman and I'm a rehabilitation psychologist and a professor in the Department of Rehabilitation Medicine here at the University of Washington. Tonight I'm so pleased to welcome my wonderful colleague, Dr. Chuck Bombardier. Chuck is a rehabilitation psychologist as well in our department, and he fairly recently completed a research study on the use of remote hypnotic cognitive therapy for pain after spinal cord injury. And so we're really excited to have him here to share the results and share background on that research. So welcome, Dr. Bombardier.
Thank you, Dr. Hoffman. Thank you, Jeannie. I really am excited to be here with you all tonight. Thank you for joining us. All right. So yes, tonight I want to talk about our study on remote hypnotic cognitive therapy for chronic spinal cord injury pain. Is it woo-woo or is it worth a look? So I'm very grateful for my colleagues who helped with this study, Dr. Elena Mendoza, Pavitra Thomas, Jason Barber, and Mark Jensen, all here in the Department of Rehabilitation Medicine. The main disclosure I want to mention is that the study hasn't been published yet, so it hasn't been vetted, so take everything I say with a grain of salt. I'm very grateful for our funding through the Craig H. Nielsen Foundation. I don't have any conflicts of interest, and I want to express a special gratitude for Dr. Mark Jensen, Dr. David Patterson, and Dr. Joseph Barber for really being the ones who envisioned the power of hypnosis to help manage pain. I also want to thank the people who participated in our research from all over the country. Without those folks participating in our study, we would not have been able to produce these results. So thank you so much for those who participate. Tonight I'm hoping to talk about a variety of things. By the end, I'd like you to be able to explain why non-pharmacological treatments for pain are needed and potentially effective. I want you to be able to discuss how cognitive therapy and hypnosis work together, and then hopefully to be able to paraphrase some of the key findings and limitations of the study that I'm going to talk about. So why did we do this study? Well, years ago, we did a survey in our SCI update newsletter to all you subscribers, and we asked really what were your top concerns. And it turned out that pain was the most frequently listed top concern. And some of the things that we read that people had sent in were as follows. One person wrote, I want to know how to deal with the nerve pain that I'm experiencing. Another person wrote, I want natural ways to relieve pain, not without drugs. And the third person said, I want help to reduce the pain in our SCI bodies. So those are some of the recommendations. It kind of just reflects how seriously we take the comments that you made, and it did lead us to doing this study. So kind of taking a big picture, like, what is the problem of pain in people with spinal cord injury? And not living with pain myself, not having a spinal cord injury, I can only express it from the perspective of an able-bodied person, but this is what we know from the scientific literature. And that is that chronic pain is really a significant problem for people with spinal cord injury. It affects more than 2/3 of the population. And about 58% have neuropathic pain, which is more that kind of burning, tingling, electric-like pain. Sometimes it feels like kind of pins and needles. And then 56% have what's called musculoskeletal pain, which is more the achy joint pain and so forth. Chronic pain, when people have it, is strongly correlated with a lot of negative outcomes, like more depression, poor sleep, even functioning less physically, not really wanting to be around people, not being able to return to work or do as well in terms of school or work, and then just overall lower quality of life. So lots of things that pain is related to that are negative, and makes it even more important to try to study ways to improve pain. There's also a huge need for non-pharmacological treatments. Our doctor colleagues, our physician colleagues are doing the best they can, working with you to try to come up with ways to kind of ameliorate the pain, to try to lessen the pain and so forth. And there's tons of medical treatments for pain. But even given optimal treatment for pain from a medical perspective, only about 50% of people, only about a third of people, 33%, experience a 50% or more drop in their pain intensity. So it leaves a lot of residual pain in people living with spinal cord injury. And then they're just, from different perspectives. For example, using opioids. We know that opioids cause a lot of harm, and there's a lot of evidence even in spinal cord injury that opioids cause harm. So that, opioid use has been curtailed. Also, a reason for doing non-pharmacological studies is that, our current model of pain is now more of a biological, psychological, and social model. So that's really the cutting edge way to see it. So we need to be looking at these psychological and social models to try to improve pain. Next is that, there's been a bunch of surveys that have been done asking people with spinal cord injury just, what kinds of things help with your pain? What kind of non-pharmacological treatments have you tried? How useful are they? And in general, those surveys indicate that non-pharmacological treatments are helpful to a large extent. And then finally, although we think that psychological, non-pharmacological treatments are helpful, we just don't have a lot of evidence to support that being the case. The most recent clinical practice guideline on treating neuropathic pain was published in 2022. And they mention cognitive behavior therapy and so forth in there. They mention hypnosis, but they really say, these look promising, but we really don't have any evidence to suggest that they're helpful. So we really need evidence if we're going to be able to, use these strategies widely. So let's kind of just take a look at, first of all, how do we think about pain? Now, this is a picture of an illustration by Descartes that tries to explain how does a person experience pain when they put their foot in a fire. And Descartes kind of theorized that there's a long fiber running from the foot up into the brain, up into the head, and that the heat it pulls fluids and makes the muscles contract. So it's kind of a silly model right now, knowing what we know now. But I want to put it out here because we still have a very similar idea in terms of how we think about pain. We mostly think that we have nerves in our hand or nerves in our leg or in our neck or whatever that go to our brain, and it is a direct signal that causes us to have pain. It's just like a one-to-one relationship. What do we have in our hand? What do we have in our leg? What do we have in our back? Goes to our brain and it signals pain. And it just turns out that it's a lot more complicated than that. So, I talked about the biopsychosocial model of pain, and this, Venn diagram just kind of illustrates some of the factors in these different categories that we know, that we have evidence that contributes to pain. So over on the biological part there, we know that genetic predisposition, affects pain. We know that, of course, that our neurochemistry affects pain. Medications, our immune system, our stress response, fight or flight, as well as psychological responses. We also know that psychological factors affect pain. So our learning history, our emotional status, what we remember, our beliefs about pain, our stress, our attitudes, and so forth also affect how we experience pain. And then also social factors affect pain, social support, our family background, our relationships, our culture, the kind of medical care that we receive or don't receive, our financial situation if we're impoverished, our exercise, and so forth. All these things affect our experience of pain. The upshot of all this really is that pain is so complicated that when you really look at pain, the most cutting edge researchers today kind of come to the conclusion that all pain is produced in the brain. So it's very different than this notion that it's a one-to-one relationship between what happens in my body and it rings a bell in my brain. It's actually that our brain decides whether or not we experience pain. So let's look at acute pain. So acute pain is pain that's immediate or less than 3 to 6 months after a person's been injured. So we have nerves in our body, and basically think of our nerves as kind of like the warning system. Think of the warning system in a car alarm. It's going to go off if someone touches the car. Well, so that's our body's trying to protect itself, has this alarm system. That's the nerves, and it's there to send us warning messages to our brain. And it turns out that our nerves send warning messages and signals to 500 different brain sites to try to decide whether or not what we're experiencing is pain. The brain decides whether the signals represent danger. And if they do seem to represent danger, if our brain decides that, then we do experience pain, and our brain guides us about what we should do to protect ourselves, like take our hand off the stove. What also happens is that the brain can stay on kind of high alert, and it can become sensitized to any new signs of danger. Like if I burn my hand on the stove, I might be a little bit wary of getting around a stove or touching a stove in the future because I remember that I got burned, and so I'm a little bit wary around that. But normally, that kind of high alert situation gradually calms down, kind of fades. The pain goes away. But sometimes the brain gets a little confused about whether there is any danger. And then we get into the situation of chronic pain. So chronic pain is really where there's still pain, there's still hurting 3 to 6 months after an injury. Now we know that 3 to 6 months after an injury, the tissues have healed. You know, the body has healed and returned as close to normal as possible, but the brain at that time, in the case of chronic pain, is still sensing danger or pain. The brain is still on high alert. It's sensitized and can't calm down. And there's various thoughts that are occurring. For example, one thought is that if I have pain, that must mean that there is tissue damage, when in fact the tissues have healed. We also have different emotions. We have fears, fear of pain, fear of doing something that might trigger pain again. And we engage in certain behaviors. For example, we might start avoiding things that in the past have triggered pain. And so our lives become kind of more and more narrow because we're avoiding all kinds of things that we think could trigger pain. And all these things kind of maintain and even amplify the sense that there's danger that our brain has to be aware of, and it complicates our experience of pain. So the goals for cognitive therapy and other therapies, but especially cognitive therapy, we'll talk about a little bit more here in a minute, is really to retrain the brain and help it kind of wind down that alarm system that's on high alert. We want to look at the thoughts and challenge the unhelpful thoughts. We want to look at the emotions and counter the negative emotions that are going on, maybe depression, maybe fear. We want to counter the avoidance and help people engage in physical activity, maybe paced activity. And we want to kind of just even use direct methods to kind of help the body and the brain calm down, like practicing mindfulness or other calming techniques. So how does the brain decide? There's something in our brain called the pain matrix, and it's made up of a lot of different areas of the brain, systems in the brain. I just want to mention a few. So as you can see at the bottom of this illustration, is really where the nerves signal, to our brain that there are, signals coming through about potential danger. It comes up the spinal cord from the body. And then it goes into the thalamus, and the thalamus is kind of our brain's relay system. And so the thalamus sends out the signals to literally 500 different areas in the brain. Here's a few of them. So looking up there in the left upper quadrant there, signals go to the anterior cingulate cortex. And this area of the brain kind of determines the emotional and behavioral responses to the signals. And classically, those can be divided into different categories. Classic categories are like fear and freezing to danger, anxiety, avoid as a response to danger, or kind of calm, confidence, and coping as a response to danger. So the cingulate cortex kind of mediates those kinds of responses. The frontal lobes also get involved, and the frontal lobes help us kind of decide on the meaning of pain, the meaning of the signals, and kind of helps us plan what to do about them if we need to, take different actions. And then the amygdala is kind of our fear kind of center, and it determines the threat versus safety level of the signals. How high is the threat, or how low is the threat? How high or low are the safety signals that the amygdala is getting from the brain, from the body? And so those are some of the centers that we know regulate pain in our brain and help decide. So one of the upshots again is that the way we think about pain, our thoughts about pain really, really matter. We know that when our brain receives positive ideas about pain, about the warning signals that are coming through, positive ideas like, ideas that there's comfort, there's hope, there's healing, that we know that pain tends to be lessened. For example, I remember going to a physical therapist about 5 years ago, having back pain, spasms, very guarded, And I was afraid to do certain exercises. And she said, Chuck, she says, motion is lotion. Motion is lotion. And I go, it's like, wow. That was like a really great way of telling me I don't have to be afraid of moving. Moving is going to help me. It's going to get my joints moving better. It's going to decrease my pain overall. That was really helpful for me. Also, just communication that, when our doctors tell us, this treatment should help you, or a therapist tells you this treatment could help you, kind of expressing confidence that that will help. Or sometimes we use this a lot, in the hospital setting where people are literally healing, especially for burn injuries. We try to distinguish between pain that's hurt and harm versus pain that's healing. And so we know that sometimes pain actually increases as the body starts to heal. And so we can literally and honestly tell people that the pain they're having is actually a sign that their body is healing. And that's kind of comforting in a way. I mean, it still hurts, but the meaning of the pain has changed. It turns from like harm to healing. And we even know that, these positive messages are mediated by certain kinds of chemicals in our brain, certain kind of chemical systems. So the opioid system gets involved, the cannabinoids system in our brain gets involved, the dopamine system in our brain gets involved, as well as oxytocin, which has to do with connection and feeling supported, and vasopressin. All these systems get involved in mediating our pain, moderating our pain, when we hear these kind of signals of hope, healing, and comfort. So it literally changes our brain chemistry when we get these signals. So negative thoughts and ideas about our pain also matter. When our brain receives negative ideas about pain, like it's something to be afraid of, it's something to avoid, it's something that I'm dreading, pain tends to be worse. For example, if a doctor tells somebody, well, it looks like you're just going to have chronic pain, your pain is permanent. I mean, that just sounds so depressing for one thing, but also it could have a biological, outcome. Or saying, I do something, we can help you. Those kinds of statements, those kinds of messages can literally influence our pain experience. And some of the chemicals that are thought to be involved are cholecystokinin, deactivation of opioid analgesic systems, and the cyclooxygenase activation. So those are the systems that seem to underlie these kind of negative messages and how they can affect our pain experience in a negative way. So to kind of summarize, because thoughts about pain matter, treatments that address the meaning of pain, treatments that address the emotions that are associated with pain, treatments that address our perceptions of threat associated with pain and our behaviors associated with pain, like avoidance, can potentially impact our overall experience of pain. Taking all these things together, people have come up with models, kind of more comprehensive models of how all this works. And one very famous model is called the fear avoidance model of chronic pain. And it's by Vlayan and colleagues back in 2000. You can see there's kind of two patterns here. On the left, we've got, first of all, in the middle and the top is injury. And then down below that is the person's pain experience. If you go to the left, you see that a pain experience can trigger pain catastrophizing, which we'll get into a little bit more. But basically, it's the ideas of kind of fear associated with pain. And that can come from kind of negative emotions or getting a lot of threatening or worrisome messages about pain. Pain catastrophizing leads to pain-related fear. That leads to avoidance behavior. And then that leads to a person kind of becoming like less active, disuse of the limb or part of the body that's been injured. Depression, because the person's not really engaging in pleasant or meaningful activities anymore. And increased disability as they become more deconditioned and kind of out of sync. And then that can kind of continue and enhance and worsen the pain experience and so forth. So that's kind of the negative cycle. On the positive side, if you have a pain experience and you somehow get to the point where you aren't afraid of that pain, you confront the things that could cause you fear or worry or cause you to maybe avoid. and overcome those things, then you go on more of a path of recovery. So that's kind of a, a way of trying to bring all this together in one model that we have used. So part of this model is this idea of pain catastrophizing. So I think it's worth talking about that since we really try to target pain catastrophizing in this study. So pain catastrophizing refers to a negative cognitive and emotional response to an anticipated or actual pain. And I had a patient in the hospital in the last couple days. They had a lot of pain catastrophizing because this person was working in physical therapy, had some pain come up, and then naturally found themselves wanting to avoid physical therapy because they were doing some activities that kind of triggered some pain. And so it started, a person who was really doing well, this person started having these pains, then started kind of anticipating that they might have pain if they did a certain thing, then they wanted to avoid the therapy, and then they started a negative spiral of not participating and getting worse. So I've seen it happen even in the last couple of days. It's when people, have kind of normal but, unhelpful thoughts, like I worry all the time about whether the pain will end. I feel I can't stand the pain anymore. I become afraid that the pain may get worse. There's nothing I can do to reduce the intensity of the pain. So, dwelling on thoughts like this, having thoughts like this can really make pain worse. In fact, 22 studies taken together have shown that pain catastrophizing is related to more severe pain and more disability in people with physical disabilities, including people with spinal cord injury. So in a response to kind of the negative impact that these pain-related thoughts and catastrophizing can have on the pain experience and on disability, people have developed what's called cognitive therapy for pain. And so really cognitive therapy is about kind of changing our thinking about pain. So what we try to do in cognitive therapy for pain, we try to focus on the helpful and less helpful beliefs we have about pain. In cognitive therapy, the therapist tries to elicit and reinforce whatever helpful thinking patterns the person has about their pain. So they might want to emphasize and highlight the beliefs the person has that this pain hurts, but it's not harmful. So as kind of eliciting that kind of thought, and try to give them a sense of control or elicit from them a sense that they can have some control over their pain, like having them recognize, yeah, there are some things I can do to manage pain. Maybe they're small, but there are some things I can do to manage it. In cognitive therapy, we try to invite people to reconsider their beliefs that are unhelpful as well, and maybe try to challenge some of those beliefs. So for example, if a person says there's nothing I can do to control this pain, we might talk with them about, well, is there really nothing that you can do to control the pain? Are there any things that seem to help you relieve the pain? And oftentimes the person will come up with something. And in this case, a patient had mentioned to me that, yeah, it's true. I mean, sometimes when I do those neck stretches, it does ease off the pain a little bit. So, you're kind of helping the person to kind of get at least a small sense of efficacy that they can have some control over the pain. This approach can be kind of didactic. It can be kind of like teaching, which we try to do. And it's best if we just tailor it to the individual person and their experiences. And we know that cognitive therapy specifically does reduce pain catastrophizing and has been used in a lot of different pain problems, a lot of different kind of chronic pain disorders, to reduce catastrophizing and to improve the control of pain. There's been one study, one kind of maybe most famous study that's been done looking at cognitive behavior therapy. So cognitive therapy plus some behavioral therapy for neuropathic pain and spinal cord injury that I want to mention. It was done by Hypnotic and it was published back in 2012. It was a randomized controlled trial of this cognitive behavior therapy versus a weightless control for neuropathic pain. They had 61 people. The treatment was run by a psychologist and a physical therapist. And the treatment was 10 sessions. Each session was 3 hours long, 30 hours of treatment. They measured pain on a 0 to 100 scale and the other outcomes as well, and they measured outcomes at 3 and 6 months. And what they found was after these 30, it was very discouraging, after these 30 hours of treatment, they found that there's no significant difference in pain intensity in the CBT versus usual care. Pain only decreased by 6%. So this is on a 100-point scale here on the right. You can see the pain went down from 69 to 65. So three points out of 100. So, and not very different than the control group. So very discouraging. So anyway, that's kind of what we knew before all this. So the good thing is that we've known for a while that hypnosis can also be useful for pain, and that hypnosis seems to work synergistically with cognitive therapy to have a larger effect. So let's just talk a little bit about what hypnosis is. So hypnosis is the ability to represent suggested events and states, like mental states, imaginatively and creatively in such a manner that they are experienced as real. So the idea that you can just use your imagination and become absorbed with your imagination, it's a powerful thing. And so it's kind of that ability to engage in that is related to hypnosis. Another definition is hypnosis is the ability to respond to suggestions for changes in subjective experience, changes in perception, sensation, emotion, thought, or behavior. So it's kind of a capacity to imagine and to respond to suggestions. So those are kind of strengths that people have. There's a lot of research I won't go into about some people think that some people are inherently more able to do hypnosis and some people are less. In this study, we didn't test for whether or not people were strong at doing hypnosis or weak. We just treated everybody, all right? So we think that if we do it well, a lot of people can benefit. We don't just have to find people who have these, rad skills to be able to do these, use their imagination or respond to suggestions. But, and so importantly, as I mentioned before, there's a bunch of prior research that shows that hypnosis can really magnify the effects of cognitive and behavioral therapy. So that's why we put them together. And that's where my colleagues kind of come in, like Mark Jensen and Joseph Barber and those guys. Before we talk a lot more about hypnosis, we should also talk about what it isn't, because there are a lot of myths about hypnosis. I mean, most people's experience with hypnosis is like stage hypnosis, where they're trying to get people to cluck like a chicken or something like that. So that's not what we're talking about at all. So one of the myths that we need to talk about is that hypnosis is like basically going to sleep when you're hypnotized. But basically, we don't want people to fall asleep. We want people to be alert and awake and listening to the suggestions and the cues we're giving them. So we don't want them falling asleep. Another myth is that people might get stuck in a trance, like just go off and not be able to come back. When what people have found about this is that people might be slow to come out of a hypnosis experience, but it's not because they're unable to, it's because they really like it. I mean, they experience a lot of comfort. It's really nice to be in that kind of place, kind of floating sometimes. So people can come out, but they sometimes want to stay there for a while. Hypnosis can be used to make people do things against their will. That's not true at all. If a person would not do something when they're not hypnotized, they won't do it during hypnosis. And remember, in these therapies, we're actually getting a lot of the ideas about what to suggest to you from you. And we're getting the most helpful parts and giving it back to you in a sense. So we're only giving you suggestions that you actually want to give yourself. Hypnotized people lose control over their behavior is another myth. People always have choice to respond or not respond to suggestions. So when we do hypnosis, we always are very permissive about it. We offer suggestions, we give suggestions, but we always say, take what you want and leave the rest. Take what's useful to you and leave the rest. And the final myth is that hypnosis exploits mental weakness. And really what hypnosis does, it exploits mental strengths. If you have good concentration, good imagination, you're able to get absorbed in experiences, those are all things that are going to help you with hypnosis. It's not a mental weakness to be able to use hypnosis or learn hypnosis. So one of the things is to talk about is just what are hypnotic suggestions? What are we trying to do here? with hypnotic suggestions. So I wanted to kind of give you an overview of that. So one of the types of suggestions we try to give people is to increase their tolerance of a sense of ambiguity about the meaning of pain sensations. Sometimes people come in with very, very fixed ideas, like, a patient of mine said, my back is wrecked, and it's like, okay, and the word wrecked just sounds like it's done, it's toast, it's never, it's bad, it's always going to be, terrible. And for people with spinal cord injury, you do have lifelong impairment sometimes. That's no question. But they don't necessarily have to be associated with pain. So sometimes we just want to have people just kind of maybe just take a step back and consider that there may be other ways to see their experience. It may be a little bit ambiguous. Also, we want to give suggestions to help them get a sense of control over their pain and its impact on them. We want to also give them suggestions to help them spend time thinking adaptive and reassuring thoughts about their pain, not as much time spent thinking frightening, horrible, anxiety-provoking thoughts about their pain. Can we come up with some reassuring thoughts? And then what we want to do, whatever those helpful thoughts are that people can get and use, we want to automate those things. We want to automate this, what we call kind of cognitive restructuring, such that any alarming or catastrophic kind of thinking are automatically noticed, they're evaluated and adjusted as needed, and transformed into more adaptive thoughts. And those adaptive thoughts can come up just spontaneously all the time. They're just always present, kind of at your fingertips in a way, to help you cope with pain. Let's see. So more on hypnosis in the study. I just wanted to mention too that as I was kind of alluding to earlier, the therapist actually gets the helpful, reassuring suggestions from the participant. We spend time with the participant asking, like, what do you want to tell yourself about your pain? What's most comforting about your pain? What have you found is helpful about your pain? When does it get better? The therapist also uses participant ideas regarding how to counter unhelpful thinking patterns, or what kinds of imagery they might, respond to help dampen some of those negative thoughts. During hypnosis sessions, participants are given suggestions for experiencing positive thoughts and experiences, as well as for diminishing the negative thoughts and experiences. And overall, the study really isn't about me or a therapist kind of doing hypnosis on you or with you so much. It's really about training the person to use self-hypnosis. It's really about us getting you started, getting the person or the patient or the client started, teaching them the skills, and then having them practice those skills. And we do that in a number of different ways. We have them do focused practice. We also record all the sessions, and then they can listen to the sessions over and over again and practice as they go, listening to the session. So that's kind of how we delivered this intervention. All right, so here's what we were trying to accomplish in this study. Our first aim was to compare the effects of 6 sessions of what we call hypnotic cognitive therapy. So that's HCT, hypnotic cognitive therapy. And we wanted to deliver it via telephone, and then later we got approval to deliver it via Zoom, so a video conference. And we compared that to usual care. And what we wanted to change, our primary outcome, was average pain intensity at the end of treatment, which was six weeks. We did 6 sessions once per week. And then we also wanted to look and see if the effect, any effect, persisted for 6 more weeks, up to 12 weeks. And then our second aim was to identify possible treatment moderators. And moderators are just like what makes a difference in terms of how effective the intervention was. And so we thought, could be male versus female. It could be the type of pain, like the neuropathic versus the non-neuropathic or musculoskeletal. It could be, too, that Zoom does way better than telephone, and telephone isn't as good as Zoom, or it could be the vice versa. But we wanted to identify that anyway, since we had those 2 different options. I'm very proud that we actually came up with this study before the pandemic. We thought, we really just want, we live in the Northwest. We're in the Northwest Regional Spinal Cord Injury System, where we serve Alaska, Montana, Idaho, Washington, sometimes Wyoming. We have a big, big region. We can't have people driving to Harborview or UW Medical Center to get treatment. We got to figure out ways to get treatment out to people. In fact, that's probably the only thing I brought to this whole endeavor was I talked with Mark Jensen about, like, Mark, we can't just have people come in. We got to go out to people, right? And so forth. It turns out that hypnosis had rarely been delivered via telehealth. People were very kind of sketchy about hypnosis, and they just wanted to do it in person, so they're a little afraid. And so we chose telehealth for a few different reasons. First of all, just as I mentioned, a lot of people with spinal cord injury don't live near specialty centers, so they can't do it. That's not good. Telehealth overcomes all these geographic barriers and other barriers. Using telehealth also allowed us to recruit people from around the United States. To do studies like this, you've got to have a good size sample. If we just got a sample from Seattle, people who could drive to Harborview or UW Medical Center, we'd never get enough people to do a real good study. So we needed a national recruitment strategy to enroll a large enough sample for a definitive trial. Okay, so what do we do? So first of all, who did we include in this study? First of all, it was only adults, people 18 and older. They had to have documented medical records that showed they had a spinal cord injury. They had to have a significant amount of pain, 5 on a scale of 0 to 10. And they had to have pain that interfered with their activities, at least somewhat. Their pain had to be chronic, at least 3 months or more. They had to communicate in English and have access to telephone or Zoom. We excluded some people, people that had severe cognitive impairment, people who had severe mental illness like bipolar or schizophrenia. We excluded people whose pain predated their spinal cord injury. If they had chronic pain before spinal cord injury, they weren't a candidate for this study. They had to have a prior medical exam, showing that they were, their medical issues had been addressed. Excuse me, if they didn't have a prior medical exam that showed their medical issues were addressed, we excluded them. If they had an unstable medication regimen, like they're changing their opioids or going on new medications or going off medications, we excluded those people or waited until things settled down. We excluded people with current or prior treatment with cognitive therapy or hypnosis. We didn't want to treat people if they already had the treatment. So, all right. We designed, so it's a randomized controlled trial. So it's like flipping a coin into 1 or 2 groups, 1-to-1, hypnotic cognitive therapy versus usual care. And just, we stratified it by sex and worst pain type. That's a little in the weeds, but we did that. Before May 27th, 2020, we delivered it all by phone, and then after that, we delivered it by Zoom. So that's just kind of how we separated it out. In terms of our assessment plan, we measured outcomes at baseline, so before when the study started. At the end of treatment, that's 6 weeks, and then follow up at 12 weeks. And the person who was doing all the assessments was kept unaware of which group the person was assigned to. And if they found out, we had somebody else assess them. So here's what we did. Here's the protocol. I'll give you kind of an outline of the sessions. All the sessions, they got pre and post hypnosis pain rating. So we asked what their pain was. We went through some breathing exercises with them, taking a deep breath, holding it, letting it go. We kind of did a body scan, helping people relax their whole body, regardless of their injury level or severity. We had them go down an elevator or a path, and then we gave them some suggestions, post-hypnotic suggestions, and we used motivational interviewing to foster them practicing the techniques during the rest of the week. In the first session, we kind of introduced them to hypnosis. We addressed the myths. We got them to tell us about a peaceful place that they wanted to go to in their mind, and got that in all their different senses. And then we practiced the hypnosis induction and to try to diminish and distance them from pain and increase their attention to pleasant sensations, not just painful sensations. Plus, we gave them a post-hypnotic suggestion to practice. In session 2, we did an induction to try to increase tolerance of uncertainty, identify helpful and unhelpful automatic thoughts, practice the induction to foster acceptance and adoption of helpful and reassuring thoughts, plus practice a thought record for the next week. In session 3, we identified positive thoughts and feelings the participant wanted to enhance. We practiced the induction to enhance helpful, reassuring thoughts and assigned a thought worksheet in home practice. In session 4, we identified positive and negative thoughts and feelings. We practiced the induction to transform negative thoughts and to create distance from negative thoughts, as well as enhance the positive thoughts. And we gave them a tutorial on creating their own self-suggestions. In session 5, we practiced the induction that focuses on promotion of well-being and included improved self-confidence and mental functioning and sleep. And then in the session 6, last session, we practiced an induction where they imagined themselves in their future self, and what they would bring back to themselves in the present moment once they were better. And we discussed maintenance and relapse prevention. So that's kind of the content. Our primary outcome was daily average pain on a 0 to 10 numerical rating scale. And we would call people 4 times during the week and ask them what their pain was, in average pain that day, and we averaged those out. So we got a really nice measure of pain by calling people 4 times in 1 week. We also used some other measures, a measure of how much pain interferes with things like mood, sleep, social, work activities. We measured depression on the PHQ-9. We used the Sheehan Disability Scale, which is basically a self-report measure of how disabling spinal cord injury is for a person. We measured satisfaction with participation in social roles, satisfaction with their ability to participate generally, pain catastrophizing, and then pain acceptance. So those are all of our measures. So we were able to get a nice sample of 127 people who were randomized either to the hypnotic cognitive therapy or usual care. 48% received the therapy via telephone, and 52% received the therapy via Zoom. So we got it right in the middle. That was great. The groups were equivalent at baseline. The average age was about 51. 58% were males. 10% identified as Hispanic. 10% is Asian. 8% is black. 2% is Native American, and 79% is white. 60% had tetraplegia. 61% had incomplete injuries. And participants were about 15 years after their injury. In terms of their baseline pain, they're almost at a 6 out of 10. Their average baseline intensity was about 6 out of 10. Average baseline pain interference was about 5 out of 10. And 57% had neuropathic pain. And by neuropathic pain, that means that they had 2 or more of the following characteristics in terms of their pain. Their pain felt like kind of electric shock-like sensation. They experienced pins and needles type of tingling. Their pain was hot, burning, or cold or freezing. Or their pain occurred in an area where they didn't have sensation. So 2 of those factors meant that they had neuropathic pain. So what are our results? So first of all, the dose of therapy. So participants completed an average of 5 sessions out of the 6. 80% completed 5 or 6 sessions. 11% completed no sessions. You know, we did this study when we analyzed the data. We analyzed people regardless of how many sessions they got. We analyzed them whether or not they were in which group they were in. So some people didn't get any sessions. In terms of study retention, we obtained follow-up data on 91% of our participants at 6 weeks and 90% of people at 12 weeks. And as I alluded to, the data analysis is based on what we call intent to treat, which is that we analyze data according to the group to which the person was assigned or randomized, regardless of how much treatment they received or didn't receive. So again, getting into the weeds, we used what's called mixed linear effects modeling that showed that pain intensity decreased significantly more in the hypnotic cognitive therapy group versus the usual care group at 6 weeks. So there's, in the hypnosis group, the pain decreased by 1.17 points out of 10 versus only about 0.58 points in the control group. And at 12 weeks, pain decreased by 1.47 points versus 0.6 points. Let me show you pictures. That's going to be better than reading this. So here's what the effects look like. So you can see at the bottom, the treatment phase is the first 6 weeks. By the end of the first 6 weeks, we do get a significant effect on pain favoring the hypnotic cognitive therapy group. It drops significantly more. And you can see, which is really interesting, and that's why the fact that we're teaching people how to use self-hypnosis, we're giving them recordings to practice with. You can see that as they hopefully practiced more and did more, their pain doesn't come back up to what it was, it keeps going down. And unfortunately, we don't have data to show how long that lasts. You know, we only went out to 12 weeks. But it looks promising that, you know, pain is continuing to go down at 12 weeks, which is a really nice finding. This looks at pain, the percent of people that had at least a 30% reduction in average pain intensity following the 2 interventions. The purple is the hypnosis group. The gold is the usual care group. And a 30% reduction is used because that's kind of a benchmark for what's called a clinically significant drop in pain that people can actually really notice. So at 6 weeks, you can see that 28% of people that got hypnosis and cognitive therapy had at least a 30% drop versus only 14% in the control group. And at 12 weeks, 38% of people got at least a 30% drop in pain versus 24% in the control group. So nice effects. In terms of reduction in pain intensity by pain type. So here's a really interesting finding. So we found here over on the left hand, you can see that in the people that had neuropathic pain, or actually we had people focus, many people have multiple pains, right? So people can have 1, 2, 3, even more pains. So we had them rate each pain individually. And so for people, everybody, we had them rate their pain, the neuropathic pain. And what we found was that there's a much larger drop in neuropathic pain relative to other pains when you use hypnosis. So at 6 weeks, you can see it's dropping by almost 1 point. At 12 weeks, it's dropping by 1.7 points out of 10. The non-neuropathic pain was kind of in the middle. It dropped by 0.28 points at 6 weeks and then 0.7 points at 12 weeks. And then the mixed pain had the worst response. Folks with mixed pain didn't hardly drop their pain at all at 6 or 12 weeks. So the nice thing about this study is that it had positive effects on other pain-related symptoms. So I mentioned before that pain can influence other things like sleep and activities and so forth. So pain interference is kind of a general measure for how much pain interferes with life. So you can see here at 12 weeks, the hypnotic cognitive therapy group had significantly less pain interference than the usual care group. Also at 6 weeks, sleep disturbance was significantly better in the hypnotic cognitive therapy group than the usual care group. At 12 weeks, the groups converged. At 6 and 12 weeks, depression was significantly less in the hypnotic cognitive therapy group than the control group. This graph, the way I've set it up, doesn't make it look like the differences are that great, but they are significant differences. The thing that we're trying to affect, this pain catastrophizing, definitely dropped more in the hypnotic cognitive therapy group than in the control group at both 6 and 12 weeks. Pain acceptance, this is an interesting finding. Pain acceptance decreased more at 6 weeks in the hypnotic cognitive therapy group. That's kind of a puzzling finding, right? But if you think about it, these people have just been given some tools to actually get a little bit more control over their pain. So why should they accept their pain when they can actually control it a little bit at least? And so our thinking is that pain acceptance went down. They were less accepting of having chronic pain because they got some sense of control over their pain and were able to, have a little bit more self-efficacy. So that's our idea there. I'm not sure. We didn't change subjective disability or our other participation measures in hypnosis versus usual care. They were the same. Okay, so what do we kind of take away from all this? Let's kind of try to wrap up and then talk about maybe future directions and limitations. So first of all, it was just 6 sessions of hypnotic cognitive therapy from a pain psychologist, and these are about hour sessions, 45-minute to an hour sessions, resulted in a significant decrease in pain intensity relative to usual care controls. And again, this is for people who don't have special hypnosis, skills. They've got all kinds of different pain. They're 15 years out. They're already on medications for their pain. We didn't make them go off their medications. So we had an effect. Reduction in pain was clinically meaningful. At least a 30% decrease for 38% of participants at 12 weeks. I don't have this on the slides, but the most commonly used medication, Lyrica or pregabalin, in using pregabalin causes I think it's about 45% of people with spinal cord injury to have a 30% decrease in their pain. That's not that much better than what this is showing. The effect of hypnotic cognitive therapy on neuropathic pain was larger than other pains. The benefits of hypnotic cognitive therapy were, as I mentioned, obtained in people who are already being treated for spinal cord injury related pain. I don't have the data on what medications they're on, but they're all on, medications. Hypnotic cognitive therapy had a lot of positive secondary effects like pain interference, sleep, and depression. And it can be delivered by telephone or video conference, Zoom, whatever, Teams, such that people living far from specialty centers could benefit. Okay, so what are some of the limitations and future research? First of all, the study used a usual care control group and was only what's called single-blinded. That is, the participants knew they were getting or not getting the treatment. So for future studies, what we should do is we should look at using what's called active control conditions that gives participants an equal amount of time with a therapist doing things that might seem helpful but don't have those active ingredients that hypnosis and cognitive therapy have. Like a placebo drug. So that's kind of another study that we should do in this area to kind of even be a more rigorous study, test of our hypothesis. Another limitation is that the outcomes are fairly short, only 6 to 12 weeks. So 6 weeks beyond the end of the treatment. Future research should assess outcomes at 3, 6, 12 months to determine how durable these effects are. Participants were on average 15 years post-spinal cord injury. If hypnotic cognitive therapy is helpful for pain, we might want to try to use it much sooner after spinal cord injury. And if it has persistent effects, that could really just change the trajectory of the pain. And that could prevent a lot of suffering that happens downstream. And fortunately, my good colleague, Dr. Amy Starosa, is leading a study here at our centers on the efficacy of hypnotic cognitive therapy for pain actually during inpatient spinal cord injury rehabilitation. So she's trying to deploy that right away and see if that makes a difference. And she already has data to show that it's pretty acceptable, able to deliver it. So that's good news, and we're keeping our fingers crossed for that study starting up pretty soon. This is the first randomized controlled trial that we know of showing that hypnotic cognitive therapy reduces pain. It's still not published, so again, grain of salt here. Typically, clinicians and scientists want to see at least 2 published studies that produce the same effect before they believe it. So we need to do another study to replicate what we found in this study before we can really push for widespread adoption. Oh, right. I thought I had one more slide, but I don't. That's the end. Yeah, so I'm glad to entertain some questions or comments.
Yeah, excellent. Thank you so much, Chuck. That was fantastic.
Oh, okay. So the asterisks on the graphs, I'll go back. Whoops. Sorry, let me go back a little bit if I can. That shows where the significant effects were. So let me just show you. Okay, so The asterisk here on depression and pain catastrophizing, that means that at both those time points, at 6 weeks and 12 weeks, the differences were statistically significant. But if you look here on pain interference, the effect was not statistically significant at 6 weeks, but it was at 12 weeks. So thank you for mentioning that. Thank you for making that clarification. Why would people get no sessions? Great question. I mean, we have people who just, say they want to do a study and then they can never be found again, or they drop out, or, I remember having a participant in a pilot study who just went on vacation, and one person whose mother got sick. It's like they just disappear, and we find later on that, oh yeah, well this happened. We had a person one time who went to prison. So yeah, all kinds of reasons.
And did you track?
Yeah, the question is, did we track practicing and to know if practice had a better effect? We did track practice, but I don't have those data for you, and we will look at whether more practice, basically doing your homework, whether that improved outcomes. So, but we don't know yet. If this works, how do people get access?
Yeah, so I mean, this looks fantastic.
Mm-hmm.
So how do people get this now?
I think it's a little premature. Like I said, what we want to do in studies like this is we want to replicate them. We want to see if they really have we can get the same effect again. All drug studies, usually you have 2 randomized controlled trials before it's FDA approved. So we need to do another study. Someone else, or we need to do another study that shows it really works again. I should mention that we did do a pilot study where we had no controls, except historical controls, and we did get the same effect. But yeah, so we need to do another study. So right now I'd be very reluctant to roll this out because it's just kind of premature. And that's a difficult place to be in right now. But I think that's what we should do so that down the road we don't do harm. We don't we don't know of any harms from this study, but yeah, we should see if it really works in other people's hands. We also had another limitation I didn't mention is we had a single experienced pain psychologist who was our therapist, Elena Mendoza, and I don't know if if we just have other people do this, if we'll get the same effect. So there's still a lot of questions. Hopefully, eventually, though, people will be able to get this. We can train people to do this fairly easily, and they'll be able to go to their local spinal cord injury center or call a center anywhere in the country, maybe, for a psychologist who has training in hypnotic cognitive therapy and get treatment by Teams or Zoom or whatever is the going telehealth, mechanism. So it could be really cool down the road. I don't know. Do I recommend people? So hypnosis is available, cognitive therapy is available. Do we just keep trying things?
For the person who wants it now.
For the person who wants it now, people can go. There's probably people out there. There is an American Society of Clinical Hypnosis. I think ACAH or something like that. And there's a lot of people out there practicing hypnosis. Many of those people probably also are experiencing cognitive therapy. And they could say, I've heard that, if you do hypnosis with me and you help me do cognitive therapy with hypnosis, that could really help my pain. That'd be a great question for somebody who has a hypnosis background. People who practice hypnosis probably know cognitive therapy. People who, if you go to someone who has cognitive therapy, they probably don't know much about hypnosis. Hypnosis is the more specialized thing. So, but yeah, I think they should try. I'm just not sure what to do in terms of rolling out something I'm not that confident in yet, but is really promising. Good question. I mean, when did those other models of pain, kind of the biopsychosocial models of pain, gosh, when was Melzack and Wall published? Like 1960s, I think? 66 or 62, a famous paper by Melzack and Wall was published. I can't remember what the journal was, called The Gate Control Theory of Pain. And that model started looking at basically how does the central nervous system modulate pain. You know, and they talked about gates and so forth and downward regulation and so forth. So, but actually some of the key observations about this go back to, I think it's World War I. It might be World War II, but I think it's World War I, where there was a key observation made by a military surgeon. They were noticing that soldiers were coming in with huge wounds, and they were needing very, very little anesthesia. These people came in, big wounds, didn't need any opioids. And then they were noticing that other soldiers were coming in with very small wounds who needed a ton of opioids. They were in excruciating pain. And so that just led these people to think, like, what's going on here? You know, there's no obviously one-to-one relationship between the wound and the amount of pain. It's like backwards. And what the person discovered when they wrote up these cases was that the meaning of that pain was radically different for those two groups. And that was what was driving their pain level. In the group with large wounds, those guys were going home. They were not going to go back on the battlefield because they were injured too severely. The meaning of pain and that injury for them was, I'm out of here. For the people who had minor wounds, they were going to go back to the front lines. The meaning of that injury was very different for them, and it affected their need for pain medications. So that observation was also, you know, a sea change in terms of recognizing that there's no one-to-one relationship between the injury and pain, but the meaning of the injury is also very significant. 1965, Melzack and Wall. Thank you.
Last questions, but Chuck, thank you so much. Congratulations. As another researcher, it's always so exciting to get fantastic results and actually have things turn out the way you want, get the right number of people, and that things actually turn out. So congratulations, and thank you so much for sharing your research with all of us. Very much appreciated.
Thank you very much for having me. It's an honor to be here. Bye-bye.